and what is the association of thyroid hormones on other hormones. So when we talk about the crosstalk of thyroid, if the thyroid goes up, where all it will act?
So basically it causes increase in prolactin levels.
That is not because of TSH, that is because of TRH. But what does TSH do directly? It will act on the FSH receptor. So it has got strong structural homology. So there is some affinity. It's not a huge affinity, but if your TSH is thousands, it is going to act on the FSH receptor to cause peripheral precocious puberty with a large ovarian cyst in girls and macroorchidism without pubarchy in boys. This is a clear-cut thing which will happen in that regard. Now, as discussed, this was the point you were saying. If TRH goes up, that will cause hyperprolactinemia, which will cause galactorrhea, amenorrhea, lack of pubic hair also will happen in that perspective. What do dopamine and glucocorticoid do to TSH?
They also cause the not BC active basically the central hypothyroidism state.
So they will suppress TSH. So you will, in somebody who is on a neonatal screen, you will have a falsely low TSH, which will happen with these agents, and that's an important thing to remember. And HCG, we already discussed, acts on the TSH receptor to cause a thyrotoxicosis like picture. So if you have a pregnant lady with severe thyrotoxicosis, what will you think of? It was not there earlier, but now she has got a lot of vomiting, not feeling well, dehydrated, and her T3, T4 are very, very high.
So some HCG secreting tumors.
Anything? Which is the most common HCG secreting tumor? H mole. Why choriocarcinoma? Hydatidiform mole. Choriocarcinoma will be later on. Na? So if you have hyperemesis gravidarum, if you have severe thyrotoxicosis, which is beyond the normal thyrotoxicosis of pregnancy, think of a H mole, and the HCG will be hugely high in that perspective. So all this overlap becomes important to understand from a physiological perspective. Now we all know that adipocytes give a signal to the brain that, okay, we have got too much fat in the body through the leptin. What does leptin do to the brain then? So leptin will say, okay, let's burn some energy. So you will have a high TRH, you will have a high TSH, but subsequently you will not have a improvement. So these are the interactions. So high TSH will cause peripheral precocious puberty in girls, macroorchidism in boys. High TRH will cause hyperprolactinemia. Pregnancy will cause thyrotoxicosis. Use of steroids and dopamine will cause low TSH. So all this you need to remember in that regards. Now, Dr. Sayan, what would you want if you are becoming sick or you have somebody who is sick for thyroid to do?
To waste less peripheral energy.
So you don't want thyroid to be active. So sickness again is when you're going into shell. So when you go into shell, you want to prevent your energy, you want to use it energy in a better fashion, you don't want to waste it. So you will go into a hypothyroid state. So what will you do?
I'll increase my reverse T3.
So illness, what you are saying to say that your DiO3 activity is going up. So RT3 will go up and the T3 level will be low. What will be the other effects? Other factors which will play a role? Illness. So one is that this MDI3 is going down, is increasing.
So other factor will be increased stress, decreasing this TSH via cortisol.
Yes. So you have got cytokines, cortisol, and non-esterified fatty acid, which also have a direct impact on the binding. So they will also have an impact on DIO1, and they will also have an impact on the TSH. So your TSH will also go down because of all these agents that are being used. Your MDI2 activity will, however, be increased because you want brain to be saved. What will happen because of that?
So the brain will get its normal supply.
And
the TSH will be further decreased.
So you will have low TSH again. So this will be, and brain T3 will be high, but your TSH will go down in that perspective. So brain is being saved, but TSH is going down. So fundamentally, and if you're using dopamine, also you will have low TSH. Cortisol will also cause low TSH. So all these factors will cause a low TSH. So what you are seeing, your RT3 is going up, T3 is going down, TSH is going down. Again, people will say, nobody measures RT3. They will say it is a central hypothyroidism in that perspective. Now, cytokines will also have an impact on TRH. They will suppress that in that regards, and that will again cause low TSH. Now, if your TRH is defective, you will produce a TSH which is detectable, but it is bioinactive. Why? We discussed this. I think you were not there. What is the, how do you decide the bioactivity of TSH? What? So TRH regulates the glycosylation. So if your TRH is a problem, even if you produce some TSH, it will be less bioactive. So a lot of bioinactive TSH will also be produced in that regards. So low TSH, and that's why your T4 will also go down. So effectively T4 will also come down, and low T3, low FT3. This is the hallmark of illness. Now what happens with recovery is that you are now getting better. Your MDI1 or DIO1 will go up, DIO3 will come down, and again you will have greater increase in terms of T3 and T4. MDI2 will go down, so TSH will start going up in that regard. So recovery will basically have high TSH, low T4. Now T4 will take time to get up. TSH will become high earlier, normal T3. So you will now think it as a subclinical hypothyroidism. So non-thyroidal illness basically in the illness phase looks like central hypothyroidism, and then it switches towards a primary subclinical hypothyroidism. But if your TSH is high in a sick child, what does it mean? It will be higher. So don't ignore that. If your TSH is more than 10, it is very, very significant.